All right, good morning and welcome back to the Action Collaborative's virtual symposium. Our next session will focus on health professional education and training, persisting gaps and promising practices. To overcome the current addiction crisis and mitigate future such crises, it is essential that the healthcare workforce have the knowledge, skills, and training required to care for individuals with substance use disorders or pain, as well as to prevent and recognize the symptoms of these conditions. I'm delighted to introduce a panel of experts and educators who will discuss strategies to close gaps in health professional education and training to improve care for people with substance use disorders and pain. The session will be moderated by Dr. Steve Singer, who is Vice President of Education and Outreach at the Accreditation Council for Continuing Medical Education. And joining Dr. Singer are Mr. Richard Botner, who is a physician assistant and an affiliate faculty member in the Department of Internal Medicine at Dell Medical School at the University of Texas at Austin. Dr. Daniel Alford, who is the Director of the Clinical Addiction Research and Education Unit at Boston University School of Medicine. Dr. Charlene Dewey, who is a Professor of Medicine and a Professor of Medical Education and Administration at Vanderbilt University Medical Center. And Dr. Deborah Finnell, who is Professor Emerita at the Johns Hopkins University School of Nursing. Their full biographies are available on the event website for you to access. And please note that we will be taking questions from the webinar audience during the last 10 minutes of the session. Please use the Q&A box on your screen to enter a question. And now I will turn things over to Dr. Singer.
Thank you, Liz. Can you hear me okay?
You're great.
Terrific. Well, it's a pleasure to welcome all of you. I really want to express my appreciation and gratitude for being part of this effort. This is going to be a conversation of colleagues and peers who are educators focused on addressing these critical issues, many of which have been so really beautifully elaborated this morning. So I'm excited by the way that we're going to specifically address a lot of the questions raised from the earlier sessions today. I'm just going to give a brief introduction, which is really kind of a summary of how the Action Collaborative's Education and Training Work Group has been approaching these issues over the past year and a half in the way that Dr. Zhao described this morning. So if I could have that first slide, Liz, that would be great. So our work group is one of several that Dr. Zhao described this morning. And the mission of our work group is here. And it is that we're together working toward a coordinated, interprofessional, patient and family-centered approach for the continuum of health professional education that addresses these issues. And if you go to the next slide, what I want to highlight is I've pulled out some of these key terms from that mission. And part of where we are currently in the work of the work group is we are moving towards sharing an action plan that really has been a collaborative effort to determine from the number of stakeholders that are part of the Action Collaborative, and several of our speakers in this panel are part of that, are part of this work group, to address these challenges in an educational manner that is comprised of connecting with practitioners to get their investment and sort of ownership from them about the educational challenges that we need to address, to collaborate across the educational community, both interprofessionally and across the continuum of health professional education, to really raise up the educational impact of all of our efforts collectively. Also to understand that the effectiveness of education, whether it's at the undergraduate training level, residency, or very importantly for practitioners or clinicians in practice or for interprofessional teams, is something that we have tools and we have methods to conduct education that meaningfully changes practice. However, there's a methodology and an evidence basis for that that might not be equally distributed across our efforts. So I'm excited about the conversation that we're going to have about how we can make sure that education equals learning and that it's productive effort and not duplicative or unproductive effort. The last thing is that we understand, and I think the discussion this morning about stigma really highlighted that there are a number of different educational gaps and practice gaps, and that the strategies that we take to address those gaps have to be complex and as differentiated as the challenges themselves. So something that I hope that our panelists will address is how do we ensure that it's not sort of one solution to fit all, but that we can have a very articulated and complex approach to really address educational challenges where they occur. The sum total of all this, and I think what I will try to help as a facilitator this morning, is to say, how can we best support educators? I think that the collaborative recognizes that there is a lot of educational expertise and a lot of educational activity that's already occurring, and that's going to be abundantly clear from what each of our educational experts are going to share. The question is, how can we work together collaboratively to support each other, and what can the Action Collaborative do really to raise all boats in the educational approach? So with that, I'd like to first introduce Richard Botner, who is a physician assistant and is going to lead us off with a brief presentation about the educational work that he's been doing at University of Texas.
Thank you so much. Good morning, everybody, and thanks for having me here today. I'll be speaking specifically about the role of opioid use disorder treatment and reducing stigma of patients with substance and opioid use disorders. Next slide, please. Early on at Del Med, we were doing a number of somewhat disconnected things around addiction, not only within our medical school, but really throughout the whole University of Texas at Austin. One of our main introductions to treatment outside of the classroom setting and education about that treatment actually started as a quality improvement project at our academic medical center. It was a partnership between our departments of internal medicine, psychiatry, and population health. And with the support of our GME programs, our residents, we launched what we call the buprenorphine team. This is a picture of the team on the screen. And it's a volunteer, interprofessional, multidisciplinary group that works to identify patients who have OUD at the time of hospitalization, starts buprenorphine as a routine part of hospitalization for patients who are interested, and then provides a referral and sort of a hot handoff, not even a warm handoff, a boiling hot handoff to a community-based treatment program at discharge. It's the only program of its kind in Texas. It's one of very few in the country. And there's actually a handout today that you can access to learn more about that program. Next slide, please. The reason I share that is because as we've worked on that program for the last couple of years, in what was supposed to be sort of this narrow quality improvement project, it really turned into something so much greater, so much better and more meaningful, not just for us as practitioners and for our patients, but actually for our trainees. So in hindsight, what we've actually done is create this ripple effect where we can have these discussions and teach about treatment and stigma and recovery, not only within our GME program, but across the whole school, including our UME program. And of course, this has tremendous ripples as our trainees graduate and go elsewhere throughout our county, our state, and our country. Next slide, please. So what we've really started to do is shift the culture to create interest in a topic, in a diagnosis, in a patient population, within an environment where that interest may not historically be strong or may be present at all. And of course, I'm referring to training environments across all of the different health professions. Early on in our UME curriculum, our MS1 students, our first year med students, participate in a interprofessional experience that crosses numerous different disciplines throughout the entire university. It's a year-long program. It meets monthly, covers various topics. one of those topics is addiction and substance use disorder. And that program, by its very nature, is interprofessional. The content for it is curated by a pharmacist from our College of Pharmacy, and it's taught by a multidisciplinary group of stakeholders from the colleges of medicine and nursing and social work and pharmacy. And so the interprofessional and multidisciplinary approach to systems of care for patients with addiction is critical. And therefore, we must teach this topic in a similar environment, in an interprofessional and multidisciplinary environment. Now, this course has been happening for the last 4 years, long before we started our hospital-based treatment program. But again, I share this because the interprofessional aspect to all of this is woven throughout our entire university and certainly throughout our medical school's curriculum. In addition to interprofessionalism, what I really want to focus on in these few minutes is stigma. We've heard a lot today about the importance of stigma. I am trained in hospital medicine. I do not have formal addiction medicine training. And when I think about the work that we've done over the last several years and reflect on my experiences and my training beforehand, as well as our kind of initial barriers to doing our treatment work in the hospital, I can't help but think about how so many of the issues around care delivery for addiction and therefore teaching about it is really rooted in this sort of deep and pervasive stigma. We haven't taught a lot about addiction within the health professions training programs, in large part because of that stigma. We haven't advanced policy in a, at the national or state level in a truly meaningful way, really because of that stigma. And of course, patients with substance use disorders are held back from employment and housing and of course, healthcare because of that stigma. And so while we've started this treatment program, I might argue that what we've done more of is start to normalize opioid use disorder as the chronic medical disease that it is by creating and pushing conversations about this that maybe weren't happening before. So the remaining initiatives that I'll briefly discuss are really focused on that piece, on that stigma reduction, with really the goal of eliminating stigma, of just completely destroying it. Specific to OUD, we've had a number of initiatives over the last few years that seek to do this. So with the support of our UME program, we engaged with medical students to put together focus groups where handfuls of medical students facilitated discussions with people in long-term recovery about stigma and how that stigma affected them. With the support of our GME program, we created a flipped simulation where we used standardized patients to play the role of the physician and the residents to assume the role of the patient experiencing OUD. After that experience, the majority of participants stated that it would really, it changed their practice and how they would practice in the future. We've offered X-waiver trainings as a medical school to our community here in Austin. We've had dozens of residents participate in those waiver trainings, including the majority of our family medicine residents. But the item that I'm probably most excited about to share with you today is our participation in the AAMC Opioid Education Challenge. So we received a grant to put together online modules that are specific to reducing stigma of patients with opioid use disorder. These are not sort of traditional voice over PowerPoint. They are interactive. They include original video content of people in recovery. They incorporate interactive learning activities. And of course, they are designed for all health professions trainees and practicing professionals. So it includes CE for physicians and nurses and social workers and pharmacists. And of course, we've built in robust assessment to make sure that we're meeting our goal of reducing stigma. And when this launches next month, it will be available free of charge, of course, because it's supported by the grant. Next slide, please. This is just a brief outline of the modules. Next slide, please. And this is a brief outline of some of the topics that are covered in these modules. And I won't read them out loud in the interest of time. Next slide, please. And this is just a brief screenshot of what the modules will look like. It's kind of just a teaser. It's sort of hard to envision what it would be like to do an interactive module with a 2D picture, but just to tease you about it. Next slide, please. So again, we anticipate these modules being available to all in the medical community sometime next month. We'll be partnering with several organizations to make sure these are widely available, and that includes Shatterproof, who you heard from earlier today. The address on the screen is where the modules will live. Right now, it forwards to our Dell Medical School homepage, but later it'll go directly to the module. So please don't hesitate to reach out to me after today about this or anything else that we discuss. And I'll close by saying that it's truly important and impactful to not only train, but to empower future health care professionals from all of our different disciplines to appreciate addiction as a medical diagnosis and to understand that there are many things that we can do effectively to help patients with that illness, and that we do the best work to achieve that goal when we do that work together. Thanks.
Thank you, Rich. Thanks for sharing your presentation. Just as a reminder for folks listening or watching online, you can chat in your questions using the Q&A box. I saw that there was just a question that came in, and we'll bring those questions back around when we open up for Q&A with the panel. Now I'd like to ask Dr. Dan Alford to talk about his experience in Boston with safe opioid prescribing education.
Great, thank you. Can you hear me okay? Good.
Yeah, go ahead.
Good morning, and thanks for having me. Let's have the next slide, please. So the agenda, I'm going to talk about an area that we started in, which was creating an objective structured clinical exam, or OSCE, for residents and then faculty, and talk a little bit about the challenges of doing that, then talk about how we took it to a larger scale through a national CME training program, talk a little bit about how do you measure success with such a large program and some of the challenges to measuring success. Next. And then talk about lessons learned and next steps. Okay, next. So the OSCE came about because I realized pretty quickly that when I would present a case that was challenging to me in primary care clinic, through PowerPoint, people would be pretty quick to respond saying, okay, this is what you should do. And I realized that it wasn't that easy for me, and that so much of what we do that challenges us around safer opioid prescribing for chronic pain has to do with communication, how we talk to patients. So luckily we got a grant through the Centers of Excellence, through NIDA, to develop this OSCE. And so the OSCE included, how do you assess and manage opioid misuse risk, realizing that not everybody has the same risk. How do you measure outcomes, right? Benefits and harms, and talk to patients about it. And then how do you assess and manage worrisome behaviors, people who run out early or take an extra dose. Next. So we targeted residents. That was the initial plan. And we found significant improvements in knowledge, confidence, and self-reported practice after going through this OSCE. That obviously included standardized patients and faculty observers. Next. But it also became apparent that training residents alone will have less impact if their faculty, who are their mentors who precept them in clinic, don't support those learned safer opioid prescribing practices through reinforcement and modeling. And as opposed to managing diabetes, where there is a real strong evidence basis and there's not a lot of variability in practice among faculty and preceptors, as you know, with safer opioid prescribing and the treatment of chronic pain, there's not a lot of evidence supporting it, and there's tremendous amount of variability. So we were hearing from the residents that they were not being supported in what we had taught them to do. Next. So we developed an OSCE for faculty so that we could teach them how to teach their residents. So we did find significant improvements in knowledge, confidence, and safer opioid prescribing practices, and in resident teaching. So that was our ultimate goal. Next. So OSCEs are wonderful, right? I mean, they are all about skills-based acquisition, People get immediate feedback. They go from station to station. They get to practice. It's tremendous, but it's resource intensive, right? It's logistically complex. It's expensive. You need trained observers, faculty observers. You need trained standardized patients. If you've got, 4 stations and a standardized patient doesn't show up, you're in big trouble. So you need to have extra standardized patients. So it's very resource intensive. Next. And really, you can only train a small number of people at a time. I mean, we would train 8 residents in a half day, which is not very efficient, but it's, the results speak for themselves, but it's labor intensive. Okay, next. So we wanted to, we got the opportunity to move this education, safer opioid prescribing education, to a national scale through the FDA Opioid Risk Evaluation and Mitigation Strategy, or REMS program. Next. And what we developed based on an FDA curricular blueprint that you need to adhere to was something called Safer Competent Opioid Prescribing Education, or Scope of Pain, which we started in 2013. And essentially it's a 2-hour case-based online, but we also do in-person trainings at various states. We've done, I think, 30 states, where we have state resource panels included. So there's, so people get to know what's available to them within their state. We've done webinars live, and then we've made them enduring. We even created a monograph for people who don't want to do it online. And most recently, I'm really excited, we created podcasts, actually 6 20-minute podcasts that go through the entire curriculum in a conversational way that I think is very engaging. Now, around that, or resources that are around this 2-hour curriculum, is we developed a trainer's toolkit because we wanted others to be able to get their learners to use the material that they learn. So we asked them to have their learners do scope of pain and then use this toolkit, which had case studies, role plays, videos, communication videos that talk about, demonstrate someone having a conversation with a patient that they're inheriting who's on high-dose opioids, or a patient who has an unexpected urine drug test result. So some of the more complicated conversations, we have these communication videos. We also created some micro cases. These are 2-minute cases, again, of very common, complicated scenarios that people have, like someone took extra pills and ran out early. How do you have that conversation? We also developed, with some other funding mechanisms, supplemental programs like, how do you taper opioids in a patient-centered way? How do you set up your practice to do this? A program for dentists, a program for surgeons, a program for emergency medicine folks. And then we did a train the trainers program. So we taught a cohort of people around the country to be able to do the in-person training of the online program. And what we found was that, that folks actually did equally well to the experts and trained a much more rural population of providers. Next. Okay, so since 2013, we've trained actually over 181,000 individuals from every state. And we did do a 2-month post-evaluation early on, and we saw that there was an increase in knowledge at 2 months, increase in confidence, and self-reported practice change, and improvements in attitudes towards patients with chronic pain who are on opioids. Next. So how do you measure success for a national program? I'll tell you, the things that are easy to measure are the things that get measured, like how many get trained. And that was the main milestone for the REMS program. That is, there was 320,000 prescribers of long-acting opioids, and so they had a certain percent that they wanted trained, so number trained. Or things that we did: improved knowledge, improved attitudes, improved confidence, improved self-reported practice change. These things are easy to measure, and they are obviously measured. Next. But what we really want to measure for a national safer opioid prescribing program is improvements in clinical performance, improvements in public health outcomes, like decreases in prescription opioid-related harm, decreases in prescription opioid-related use disorder, overdoses, deaths, emergency department visits, diversion. So these are all public health outcomes that we would like to see this training impact. And then finally, I think probably most importantly, we'd like to see improvements in patient outcomes. Are we seeing patients who are treated by these learners have decreased pain, improved function, and quality of life? Next. But the challenges are, next, from a CME perspective, it's really hard to get data from participants, right? People don't do continuing medical education expecting to do pre and post surveys. And so the response rates are generally very low. We want to limit the burden to participants. So we saw that when we did a pretty aggressive pre-survey before, there was a big drop-off. People just dropped off and didn't take the program. So once we got rid of that, that was no longer the problem. Limited access to participants at follow-up, and the data is self-reported, right? People are saying, yeah, I made this practice change. Well, what does that mean? Next. It's also really difficult to attribute the changes that we're seeing to the education because other things are going on simultaneously. There's naloxone co-prescribing and distribution. There's expanded opioid use disorder treatment. There are the prescription drug monitoring programs, law enforcement closing pill mills, national and state guidelines, insurers putting in prior authorizations. So are the changes in overdoses, are the changes in people becoming addicted related to prescription opioids the education, or is it one of these other things that are happening simultaneously? So we're not working in a vacuum. Next. So to me, the lessons learned from these two major educational endeavors, yep, next, is that we definitely need to include foundational knowledge because there's been a lack of that historically in medical school, in nursing school, in social work school, pharmacy school, you name it. But we really need to focus also on communication skills acquisition. How do you talk to patients in a way that you're not treating them as a suspect or a criminal? You're treating them as a patient who has a chronic problem and you're trying to manage them with a medication that carries a lot of risk. And so how do you have those conversations? Next. It also can't be about prescriber education. And there's been so much focus on let's train prescribers. How many prescribers have you trained? But with anything complicated and time consuming in primary care that we don't do it alone, right? We involve an entire healthcare team. When I have a patient with diabetes who I'm starting on insulin, I know that my nurses and my pharmacists can help me. Well, with safer opioid prescribing for chronic pain, the nurses, the pharmacists, and everyone else has been inadequately trained, as has the physician. So we can't expect that they are knowledgeable to help us manage these patients. So everyone needs to be trained, and everyone needs to be trained now. It can't be this stepwise process because, as I mentioned with residents, the residents and faculty need to be trained simultaneously. And the entire healthcare team needs to be trained because if you're training prescribers first, and they get no help, it's going to be really hard to implement some of the strategies that we talked about, including universal precautions, using agreements, using urine drug testing, pill counts, the prescription drug monitoring program, and so forth. Next. We need to determine, so, it'd be easy to just say, okay, what's the harm in doing education? But really, it's a time commitment for people, right? And because opioid education is becoming more and more of a mandate at the state level as a quote unquote solution to the opioid crisis, it's an easy thing to mandate, right? Say, listen, education has been inadequate, so let's require everybody, all practicing clinicians to do opioid education. But the question is, does it work when you mandate it? And we've gotten we took a preliminary look of people who went through the training in a state that didn't have a mandate versus those that had a mandate. And I'll tell you that the people who went with a mandate were less satisfied with the exact same training, and were less saying they were less endorsive of I'm going to make a change. So we're seeing differences in people who feel that they had to take it versus people who are voluntarily taking it. Next. And so maybe actually it isn't about educating everyone, right? Maybe it's actually ensuring that everyone is competent, right? So some people probably are quite good and they shouldn't be forced to do the education. But I think if you're going to have a DEA license and you're going to prescribe opioids for chronic pain, then you should be able to show or demonstrate some level of competency. And the question is, how do you do that on a national level? And certainly we can talk more about it, but there are adaptive learning platforms where people, kind of take a test and don't have to do the education if they answer questions successfully. And certainly I've worked with the New England Journal of Medicine Knowledge Plus program on developing an adaptive learning platform that's out there. So there are ways to do this. Next. And that's it for me. Thank you.
Thanks, Stan. Terrific. Now I want to introduce Dr. Charlene Dewey, who's going to talk about her experience. Charlene, are you on? Make sure that you're unmuted.
Hear me?
Softly, but yes.
Okay, I'll try and speak loudly. Is that better?
Much better.
Okay. Well, thank you, Steve. Thank you to my panel speakers. Thank you to the National Academies of Medicine for allowing us to have this platform. And I always say thank you to the team that supports everything. So Liz, Aisha, and Jared, thank you guys for all of your help. Next slide. I'm going to start with a simple reflection. This is a patient. Her name is Miss Sally, and she's 53 years old. As a female, she has used opioids in various formulations over the past 9 years. After motor vehicle accident, and she now has chronic low back pain and fibromyalgia. She drinks on average 1 to 2 glasses of wine over most days of the week in order to help with her sleep and reduce anxiety, for which she's also on 1 milligram of Xanax nightly. Her previous physician recently passed away, so she presents as a new patient in your clinic. The healthcare provider, be it the advanced nurse practitioner, the physician, the PA, will take a quick history, complete a physical exam, and may quickly refill Miss Sally's medications as requested. We would consider this a misprescribing event, and there would be at least 10 different reasons that we would understand about how physicians prescribe. So on next slide. From that typical case, what we have found is that we have this unique situation in which, in my role as an assistant dean and director for the Center for Professional Health, where for the last 30 years, we've trained physicians, PAs, advanced nurse practitioners, dentists, et cetera, in the professionalism topic of proper prescribing. What we found is that there were many lessons to be learned. And again, it's from this unique look in that we're looking backwards. So we're looking from what the outcome was, whether Miss Sally ultimately died of an overdose, or whether she got sick or went to the emergency room, or maybe she didn't have a significant complication, but she wasn't really addressed as far as whether she has a potential opioid use disorder or multiple drug use disorder. And so we see things from the back end. And so we're trying to fill the gap of looking at what physicians do that get them in trouble and that what could get their patients in trouble. Next slide. So those lessons that we learned help us have a better understanding of what is actually lacking in some of our educational efforts. We've identified gaps such as federal rules and regulations that are not always clearly found, not always taught to providers. We have found that they have very little understanding about what misprescribing is and how easily even a good intended provider can fall into a misprescribing pattern. We've also found that their understanding of substance use disorders and opioid use disorders are not very strong. They have significant stigma and bias, as was pointed out by previous speakers. They aren't very well trained in SBIRT or how to use appropriate screening tools to make it a more efficient process in their clinic. And they have personal challenges, which Dan kind of just talked to a little bit around, not having been trained on some of the effective communication strategies, the conflict management, the emotional intelligence to be able to handle a patient who might be stressed or distressed or disruptive during the clinic visit. They might have their own personal biases and their own personal stigmas related to substance use disorders that might also be a challenge for them prescribing in a safe way. And then there's office-based challenges. In this day and age of the quick get people in, get people out, is the example of that typical case I gave with Miss Sally. not enough was done to adequately assess that patient and to do what was best for her as an individual, for her as a family member, for her as part of community. So all of these things were identified as gaps. And so what we've done is we've looked at different educational interventions that can be helpful. We've published on some of these. We've also used simulation training and OSCE type instructional strategies to help train physicians to interact with patients in a better way. We've also put together programs and teaching activities that we do in and outside of Vanderbilt. We developed competencies and are developing EPAs now. And it's all around the, again, this aspect of the backwards look. What is the outcome we want and what's the competency we need to develop? We've developed different tools, kind of like Dan said, like a teacher's toolkit, so to say. We have this teaching proper prescribing controlled prescription drugs, a guide for clinical teachers based on 16 different tips that we've gathered through what we see that physicians and other providers need to improve their prescribing practices. We've developed web-based modules that go along with this. We have live training, of course, and then we have these other clinical and practical tools that help individuals in the clinic setting. Next slide. So one thing that we know is that we have these assumptions, and the assumption is that teaching equals learning. But we also know that that's not always true, that learning might not be sustained. Learning doesn't necessarily always result in a skill or a change in attitude. So we have to look at the domains of which we teach. Next click. So if we look at education and education in different venues, different formats, different levels that increase learning, so that we look at whether learning is actually occurring and what is being learned, because we've all heard of the hidden curriculum and those kind of things that will perpetuate things like stigma. We want to make sure that the learning is the proper learning and that that learning translates into behaviors, and those behaviors translate into clinical performance, and that clinical performance results in outcomes that are positively impacting our patients and our healthcare society. So as a curriculum designer, we look from the outcomes first, looking backwards. Next slide. And so we have to think about, for all of opioid education, not only what we teach, but how we teach it. What tools and strategies are we using that increase that learning that can translate into behaviors? When do we teach it? What's most important at different cycles? What's most important for a medical student or a nursing student compared to a resident, compared to a practicing physician? And when in that sequence does information need to be reapplied so that it builds upon what they've learned previously? And then to what degree, which helps us understand, as Dan was getting to, the point of competence, and whether we train people to leave our training process with some minimum level of competence that can result in performance. And again, that is being measured by the outcomes that they have on patient care. Next slide. So we can look across the continuum and see that in UME, GME, CME, or community-based education, which means students, residents, practicing clinicians, and in the community, that there are different levels of what should be taught. There's also different methods that might be better at doing that. And there might also be different specialties that need slightly different educational focus compared to others. So primary care and how they differ from the general surgeon or someone who's doing procedures that will prescribe an opioid that's different than, say, for example, an anesthesiologist. Next slide. And so just, okay, so if we move on then to this one with the opioid education, all right, I'll go back. And just emphasizing this example of GME, in that proper prescribing practices really start at the GME level. And so we need to think about what's pertinent to that prescriber at that time and what general formats of teaching are going to enhance not just knowledge, but also attitudes, behaviors that can then translate into performance. And then we need to measure those things. Next slide. And on this one, looking at the big idea of curriculum designing, there are elements that are consistent. One of them is, if you click, you'll see that faculty development comes up in every one of these areas, because faculty can thwart very good efforts, especially around stigma and treatment for substance use disorders. The terminology that was brought up earlier in the first session or two, if faculty aren't using patient-sensitive language, then how will our residents and our students learn to use patient-sensitive language? And then also thinking about in the public interest and how we do that, I think academic health science centers play a role in educating our patients and educating our public around these issues. And that's where these partnerships become so important. If you click once, we'll just highlight that in CME, for example, this is, Dan was alluding to this, the importance of not only just their individual level. So these are people who are now out in practice. We can give them knowledge through webinars, we can teach them content, but until we know what they're doing in their office practices, we don't know that they're actually improving anything that translates to a patient outcome. So we want to see what they do in their office level and help teach to that. And again, giving them learning tools and job aids are really critical as far as an instructional strategy. I came through the training at Harvard Macy for Leaders in Education, and one of the quotes I came out with was, make the right thing to do be the easiest thing to do. And so almost every tool or thing I develop is about making sure that the provider can implement it easy and effortlessly in their clinics. Next slide. So in summary, I think that there are still gaps and challenges that we have to face. And we have to realize that our experience is going to be a little bit different, because again, we're looking at it from the backward end of people who've already gotten into trouble. But I think the benefit of that is that it helps us really hone in to what is the minimum skills that our learners need in order to prescribe safely. So if we click once, we'll see that I believe that education can be informed by our learned experiences. So from everyone across all the different levels, using reflective practices, using experiences that help influence attitudes is really an important piece. Next. And that education should be designed to promote learning, positively influence attitudes, but also to enhance skills that result in these improved performances that are directed toward the desired outcome. And that's always going to be patient safety, patient treatment outcomes, things like that. Next one. And then lastly, curriculum designing for opioid education really is going to require many individuals. You have to think about across the continuum, having that team, and I think Rich talked about this, of having those individuals that are going to be the catalysts, the go-getters that get it done across all the different training levels. And so I will also say that we have one of the AAMC grants, and we're now taking our blended learning program of using these 16 teaching tips to train faculty at 10 other institutions. And then those 10 faculty become the opioid prescribing champs for their institution, where their residents and their faculty can train in our learning-based platform, where they get the 7 modules for proper prescribing, but they also get teaching tips, they get the teaching tip guide, so that again, this can be disseminated across different institutions and different departments. Thank you.
Thank you, Charlene. Terrific. Now we're going to turn to Dr. Deborah Finnell, who is going to share with us a nursing education perspective on these gaps.
Great. So again, I want to echo my thanks for being part of this panel. In my presentation, I'm going to start with talking about what we've done in terms of higher education, some continuing education, and then promising practices and persisting gaps. So in the next slide, you can see that one of the initiatives has been funded through SAMHSA and through HRSA grant funding. We've received both of these at Johns Hopkins, but a number of schools across the United States have also received these grants to infuse substance use content into their nursing curricula, both the pre-licensure and advanced practice curricula. And so far, in total, about 75 schools that have received this SBIRT funding, and those include nursing, social work, and others. SAMHSA first initiated these grants in 2013 for expanding beyond medical schools. In the next slide, you see that some initiatives specific to opioid-related content. And in the face of the epidemic, the American Association of Colleges of Nursing worked with the White House to initiate an opioid initiative pledge. And we had 200 member schools that signed on to this pledge. And recently there was a survey last year of trying to determine what schools have done with that pledge in terms of educating around CDC guidelines and also what they've done in terms of integrating content into their curricula. And in 2019, SAMHSA provided funding for schools of medicine, physician assistants, and nursing with a focus there on nurse practitioners for the purpose of enhancing or introducing content related to the safe prescribing of opioid and also to advance the number of providers who were able to prescribe buprenorphine. What we did at Hopkins was focused on content related to safe prescribing, management of chronic and acute pain, addressing stigma, and culminating with ensuring that students had 24 hours of education for the buprenorphine provider waiver. And in the next slide, you can see that another opportunity was provided by SAMHSA in 2020 for curriculum that's related to the identification and treatment of substance use disorders. And this was particularly focused on professional schools or schools that were professional organizations to try to further disseminate education into the workforce and into other schools across the nation to ensure that students receive this valuable information. In year one of these grants, the charge is to pilot the curriculum, make revisions with 10 pilot schools, and then in year two, with an additional 10 schools to continue to provide that curriculum. And also one of the charges was to develop content, education, or questions that would be put on licensing exams or certification exams. And I'll talk about that in a minute in terms of some of the challenges. In the next slide, one of the things that Dan mentioned was this challenge between, as we're educating students and the students are going out into clinical practice or working with faculty educators, that they weren't receiving the same information as our students were. So our students were getting pushback from their clinical preceptors with, we don't do that here, or you're not using the right screening measures, etc. So with funding from SAMHSA, we were able to launch an online education program that was focused on screening, brief intervention, and referral to treatment for healthcare providers. And another grant that we received was through the CDC and the American Association of Colleges of Nursing, that was also received by the University of Pittsburgh School of Nursing. And rather than kind of replicating two different projects in two different universities, we collaborated on a project that would bring the expertise of our two schools together. And we developed a self-paced online course specifically focused on alcohol screening and brief intervention. In the next slide, one of the things that we realized is that we had competencies for nursing related to substance use, but we didn't really have competencies that were multidisciplinary competencies. One of the things that we did was with SAMHSA funding, again, from the State Targeted Response Technical Assistance Consortium, lead physicians from the Emerita, our professional organization, wrote competencies for physicians, for nurses, for social workers, and for physician assistants and pharmacists. And we identified core competencies across all of those disciplines. So we really wanted to have what were the outcomes that we were expecting nursing graduates from our schools to attain, and also nurses who were in practice, whether they be generalists or advanced practice nurses. And then another opportunity that we realized was that if we were going to, in fact, move this content across the United States in nursing curricula, we needed to provide some guidance for nurse educators. And so 3 of us who were funded by SAMHSA for integrating substance-related content into our curricula collaborated on a document where we looked at the American Association of Colleges of Nursing essentials that are used to guide and build curricula, and map the content that we believed was essential to those essentials. And our goal was to provide guidance for other nursing schools and other nurse educators across the United States so that we could really infuse this into all nursing schools across the United States. In the next slide, I talk a little bit about promising practices. And I highlight here a systematic review and meta-analysis that was done by Platt and colleagues in 2016, where they looked across 52 trials with different providers providing brief interventions. And these trials focused on alcohol use. And what they reported was that those that were delivered by nurses had the most effect in reducing quantity, but not frequency of alcohol consumption. And this was important validation for many of us who had been championing and writing policy papers about encouraging nurses to become engaged in this important evidence-based activity. In the next slide, one of the other things that we can see, this comes from Barnett, published in 2019. In 2017, nurse practitioners and PAs have been allowed to obtain federal waivers allowing them to prescribe buprenorphine. And this was legislation that was extended in 2018 to the other roles of advanced practice nurses. In this map, it shows the buprenorphine treatment capacity that refers to the number of patients that are potentially treatable by nurse practitioners and PAs to prescribe buprenorphine in a county per 100,000 population. And so you can see the point here is that where nurse practitioners and PAs are really stepping up efforts in rural counties are very difficult to reach populations and where they're making a significant impact. One point I would make is that nurse practitioners and PAs who start with a waiver have a minimum of 30 patients, and that can be expanded to 100 patients after 12 months. And another point that I would make is that nurse practitioners in Tennessee, as well as our PA colleagues, are specifically barred from prescribing buprenorphine. In the next slide, I talk here about some of the persisting gaps. So we do not have widespread dissemination of evidence-based activities in practice. That has yet to occur. We have essential substance use related content that's absent or limited, that's on nursing licensing and nursing certification examinations. And the requirements for obtaining and utilizing that X waiver for buprenorphine limits the access to and receipt of treatment. And I end in the next slide with a couple of maps side by side. There's a persistent gap on restrictions on practice for advanced practice nurses in many states across the United States. So these are maps from the American Association of Nurse Practitioners website. On the left, the map shows states in green that have full practice authority for nurse practitioners, yellow for reduced practice, and then red states for restricted practice. The map on the right denotes states that have made changes since the COVID-19 pandemic. And states with full practice authority are noted here in that light gray. There are 22 red and yellow states that have suspended or waived aspects of the practice agreements, and 7 red or yellow states have not taken any action. And the point that I want to make is that with the pandemic and lifting some of these restrictions among those states really illustrates that we have the need to bring this advanced practice nursing workforce to full scale. And it is past time to move all states to full practice for nurse practitioners. And the last slide is just references that I cited during this presentation. So Steve, I'll bring it back to you.
Thanks, Deborah. Okay, terrific. My brain is sort of overflowing. I think that through the 4 of your presentations, we've really gotten a very interesting perspective on really the diversity of educational approaches being taken. Deborah, ending with your presentation was a great demonstration of workforce and other regulatory related challenges and opportunities. So before we've been watching questions come in through the Q&A box. Before I circle back with some of the audience questions, I'd like to pose one question to all 4 panelists, and maybe you could just respond very briefly. We've heard about, and I think from our own settings, we know of the tremendous impact that COVID-19 is having on the work that we're doing and the communities that we serve. Through an educational lens, I would ask for each of the panelists to just take a minute to reflect about what you see as a significant impact and challenge with regard to the educational work that you're doing, and also describe for us some strategies either that you are taking currently or that you think that you will be taking in order to meet this challenge. Why don't we start, can we start with you, Deborah, and then after you, Charlene, Dan, and Rich.
Great, thanks. So I think this kind of ties in with the stigma, and one of the things that is alive and well is the moral paradigm. I have for 20 years been pushing, promoting the science base, the neurobiological base. I think we have to really understand that these are brain-based diseases and disorders, and to understand it from that perspective, just as we do with any other chronic health disorder. I think the other thing is the immersive competencies that I mentioned earlier. There are core competencies that really cut across all of the disciplines and all of the professions. And if we can look at an interprofessional education approach to address that education so that all of us are as pre-disciplined or pre-professionals are sitting in the same room and learning the same content, then we can look at how do we move that into practice. And then in practice settings, I think we have to look at how do we utilize the talents, the knowledge, the competencies of all of the healthcare professionals within the culture of the healthcare setting to provide that pipeline, if you will, from screening all the way through to treatment and referral to treatment if that's required. But I think to really look at how do we do, as Rich coined, the hot handoff instead of a warm handoff.
Thanks, Deborah. Charlene, can you respond as well?
Sure. In my interpretation of your question, looking at what significant challenges we have and what strategies are we taking during COVID, I see some of the big challenge as continuing education with an emphasis on caring for patients with substance use disorder being a challenge because everybody's focusing attention toward the COVID-19 patients. And we don't want to leave the rest of our patients feeling like they have no place to go or to have access to their providers. So certainly keeping a message that is alive saying that we always care about you no matter what your condition is, even during this pandemic, we want to take care of you, I think is really important as a big strategy to help us get over that challenge of making some of our patients feel isolated and maybe even experiencing more stigma than they usually would. I would also say the challenges around education can be significant if our faculty, again, in the faculty development range, aren't trained or prepared to take education in a different venue. So for example, our courses, our last prescribing course was the first week of May. And so when COVID happened and we started shutting down everything in March because all of our trainings are live trainings, we had to quickly shift to an online platform. And how to do that to continue and maintain the instructional integrity of making sure that our learning outcomes are going to be adequate was certainly a little bit challenging, but because we had very intensive skills-based training, we had to come up with, you know, a little bit slightly different way of doing that. But we still had our standardized patients come into Zoom. We still used groups. They still practiced asking patients questions and doing histories. So it's that flexibility and being nimble enough to translate some of our educational things to online learning quickly. And then the last thing I will say is, you know, in education, we have this delay of when studies get done to when they get published, to when we read them, to when we actually make a change, to maybe when it gets accepted into somebody's curriculum. And so things that our educators can do, for example, I listened to the NAM webinar 2 weeks ago on addressing substance use disorders during COVID. And from that presentation, I made a short module, put that in our learning management system, and sent it out to all of our grant participants. Now, I can't make them do it, and I can't make medical schools use those tools. But what we can do is try and get them prepared quickly and decrease the lag time from when we find this valuable information to the time we get it to our learners.
Thanks, Charlene. Dan, would you like to respond as well?
Yeah, sure. So in terms of COVID, so all of our live meetings were canceled and we are doing monthly webinars in different days of the week and different times. We also we've added some content because clinical care has changed. We're not seeing patients in person, so we can't do urine drug tests or you know, we don't see them. So we talked about the DEA guidance that we don't need to have inpatient contact, even with a new patient that we're prescribing for. We just need to do a telemedicine visit. And they've also given guidance in terms of how we can communicate with pharmacies around even Schedule II prescriptions. So we've changed the content to include changes in practice, you know, kind of telemedicine, but also how to interact with pharmacies during this time as well. And I say lastly, the timing of our podcast release was perfect because I think people who are juggling a lot of things at home, including taking care of their kids and trying to like learn and everything else, podcasts are what people seem to be turning to. So be able to do, you know, 6 20-minute things while they're doing other stuff, I think was a good opportune time for us to release our podcast. So that's pretty much what we're doing.
Thanks, Dan. And Rich, maybe a final word about this question?
Sure. So I think, you know, when we think about COVID and sort of the public health response, my mind sort of immediately again goes to language and to stigma. We've been promoting this idea of social isolation, where what we really mean is physical isolation. And I'm very concerned about the impact of social isolation on our patients and our people with addiction. We have an abundance of evidence and knowledge that social distancing, that social isolation can trigger recurrence of disease and make existing disease worse. So we're really concerned about it and want to be educating around that. So we've done a number of things. One is trying to increase our education around telemedicine, not just from a clinical perspective, but also from a practical one. So with regard to treatment, I'm sure we're all aware that the DEA has been more lenient, if you will, with some of the methadone and buprenorphine regulations during this time. And so educating our trainees about what that means, even if they're not in a position today to prescribe those medications, understanding the regulatory response in times of public health emergencies, I think is important. Our Foundations of Interprofessional Collaborative Practice class that I mentioned earlier, we actually did take our last section of the class, which was supposed to be a end-of-life counseling palliative care standardized patient lab, and moved it over to Zoom. And I have to say, from my perspective, I actually think there were many aspects of it that were better on Zoom by having it a telemedicine interaction. And we were very intentional before and after on educating students about best practices for engaging in a telemedicine interaction. I strongly believe that even when this pandemic is over, there's going to be a lot of increased usage around telemedicine. So educating our trainees around that and how it relates to all diagnoses is important. And then I also think, the pandemic, just like the opioid epidemic, is really bringing to light our broken healthcare system and all of the many different healthcare disparities that exist. And there's been a lot of discussion around that. And I think we have a unique moment in time where we can leverage, for lack of a better word, all of the healthcare disparities that are happening within COVID and help our trainees relate that to other healthcare disparities that we've seen. And certainly the opioid epidemic has an abundance of healthcare disparities. So we're doing a lot of that education. And then finally, I think this is a really good opportunity to help trainees find their way into advocacy. I don't think we promote that well enough across the health professions about the role that trainees can play, not just advocating in their professions or for their professions, but advocating for patients and for systems change. There's a lot of sort of political discourse happening in the country now, and I think this is a really great time to help take some of those discussions that I think a lot of our trainees are having amongst themselves and help them kind of hone that, and certainly looking at that through a lens of substance and opioid use disorder is a really valuable one.
Thanks, Rich. So thank you for all your responses. And I think, Rich, you've sort of teed up a good note for us to end on in just the last few minutes that we have. Dr. Zhao described at the very beginning of his comments that this is a crisis that we cannot solve by ourselves. And each of you have talked about interprofessional approaches and multi-layered approaches. As a final comment, and we'll sort of go back around again, and Rich, we'll start with you. As an educator looking to other educators, do you have, my question is, what do you need, or what piece of advice would you give to other educators about how we as a community can best support improving the impact of our efforts overall?
Absolutely. From my perspective, the interprofessional and multidisciplinary aspect of this education is absolutely critical and paramount. This is a sort of new world of education, not just because of COVID, but because of all of the different types of topics that we're trying to teach. From a stigma standpoint, this idea of the hidden curriculum is really serious. And I know some others have discussed it. There was a New England Journal article last year talking about a UCSF medical school student who passed away during medical training from an opioid poisoning. And the authors of that paper, I think, were really reflecting and questioning about how stigma and our assumptions about patients with addiction are somewhat universal. And and a detriment to our healthcare system and to patients. And I think one of the things that they were trying to figure out is how could they have done better? And one of those aspects, one of the ways we can do better is offering that interprofessional perspective. So the program that I spoke about earlier, our buprenorphine team program, that program includes pharmacists, nurse, PA, advanced practice nurse, physicians from psychiatry, internal medicine, palliative care, social worker, chaplain. I don't think we could be more multidisciplinary in that group. And it's 100% because of that multidisciplinary perspective that we bring to the table that we've been able to accomplish our goals of not just treating, offering education about treatment and actually offering that treatment, but reducing, stigma. And so again, I think we learn so much from each other, and we take those lessons that we learn from each other back to our various disciplines. And those of us in this program today, we're the champions, right? We're the role models. And I think it's really important that we encourage those cross-disciplinary and cross-profession collaboration. It's absolutely critical.
Thanks, Rich. Okay, we're in the final minute, so just a lightning round from each of the panelists. Maybe one or two words of what you think is the key thing that as educators we could contribute to each other to help us make our efforts more effective. So Dan, we'll go with you first.
Sure. So when it comes to safer opioid prescribing or the management of chronic pain, because there isn't a robust evidence supporting and because it's so subjective in terms of the patient interaction with benefit and harm, you can't just transmit knowledge. We really need to focus on communication and being empathic for patients and paying attention to the patient experience, right? You can't just create a bunch of checkoff boxes, urine drug test done, agreement done. You really need to think about how is the patient's experience during all of these kind of procedures that we're doing to keep them safe. And it really has to do a lot with communication skills. So focus on the challenges that people are going to have in this area where everything is subjective and not very evidence-based.
Great, Dan. And I take that also as an imperative that we should and can include patients and families and others with lived experience as partners in the education that we're developing and providing. So I know that many of you are doing that, but I'm taking that from your comments. All right, Charlene, a quick comment.
Mine would probably be the collaboration and quick dissemination of materials. There are plenty of us that have great things that we're doing, but the more we can get it out there, the more people have the opportunity to choose which ones fit their model for teaching best, I think would be beneficial for all of us as educators.
Terrific, thank you. And Deborah, you've got the final word. What can you share?
So I think I would concur in terms of the cross-disciplinary sharing. And so many schools of nursing that I know of are struggling with either trying to get this content into curricula where they do not have subject matter experts, and to use the collective of the subject matter experts across disciplines to really push this throughout the United States.
Terrific. All right, well, thank you to the panel. Thanks for all of you listening. I'm going to hand it back to the National Academy staff, but we appreciate your time.
Thank you, Steve, and thank you to all of our panelists for your terrific presentations and discussion. We're now going to take a relatively short lunch break, at least for those of us here on the East Coast, and we'll return with session 3 at 12:40 p.m. Eastern. Thank you.